Good afternoon. The General Recommendations Work Group publishes every 3 to 5 year in 3 to 5 year intervals at MNWR, and it's a fairly comprehensive document that addresses immunization issues that are relevant not to a specific vaccine, but including all vaccines. And it can address topics ad hoc that usually cannot be attributable to a single vaccine. This is a beautiful rendition of what the MMWR looks like. It's a fairly lengthy document. And these are the topics for revision. And today we're going to vote. We'll have our first vote on the first half of the document. We're going to talk specifically about timing and spacing of immunobiologics, contraindications and precautions, adverse reactions, reporting adverse events after vaccination, vaccine administration, and then talk about storage and handling. It's an ongoing revision process, and this slide basically shows you when a lot of these issues were discussed in previous meetings dating back to a few years. And we need a vote for CDC clearance and posting, and that's what we're going to do today. So since the last ACIP meeting, major revisions have occurred in 4 areas, and these are the ones that Andrew Kroger is going to be discussing today. Timing and spacing, contraindications and precautions with regard to vaccination and anesthesia, surgery and hospitalization, vaccine preparation and timely disposal, and clinical implications for non-standard vaccination practices. We're going to also update our vaccine information sources. And with that, this slide shows all of the members of the working group, which are acknowledged here, and particularly our CDC lead, Andrew Kroger, who will be speaking next. Thank you.
Okay, thank you, Dr. Vasquez. As mentioned, the content to be discussed today has already been presented to ACIP in meetings past throughout the past year. And so I'm going to basically do a bit of background for each of these four major topics, and then explain where we were at the time that the content was presented to ACIP, talk about what has happened since then, and then show relevant content. And for each of these topics that I'll describe, I will be referring to the draft statement that you have. You have the statements in front of you, the draft statements, one in track changes and one in clean. I'll have some page numbers and line numbers that will kind of tell you that are connected to the clean version, tell you exactly where we are, but I'll also be showing actual text up on the screen as well. And so I'd like to start with the topic that really was after the 2011 iteration of the General Recommendations was published. We already got a head start on this particular topic. And it falls under the section of the General Recs entitled Timing and Spacing of Immunobiologics. And the subtopic is febrile seizures and simultaneous vaccination. So focusing on that specifically, this section was presented to ACIP in February of 2013. For those that were here at the last meeting, ACIP meeting in June 2014, the Immunization Safety Office did present new data on this topic, but really the upshoot's going to be that we are not planning to make a change in the language that you were presented with in February 2013. But let me give you some background just to kind of give you some context to this issue. Basically, in 2010, there were follow-up reports of febrile seizures following use of afluria vaccine in the Southern Hemisphere. increased rate of febrile seizures, 9 febrile seizures per 1,000 doses, as well as high rates, and that was in 6 months through 4 years, and then high rates of fever in children 5 through 8 years of age. So follow-up safety surveillance by the Immunization Safety Office did detect increased rates of febrile seizures in children 12 through 23 months of age receiving, and they looked at simultaneous vaccination of inactivated influenza vaccine, or IIV, and PCV13. These data were presented to ACIP actually back in February of 2011, 1 month basically after the last iteration of the entire General Rex was published. And data and information has been published as well in subsequent influenza vaccine-specific ACIP statements. So anyway, here is kind of the specific language that we are going to use. And I'll just kind of read it. During the 2010-2011 influenza season, surveillance systems detected safety signals for febrile seizures in young children following TIV and PCV13 vaccines. CDC studied the healthcare visit records of more than 200,000 vaccinated children 6 months through 59 months of age through the Vaccine Safety Data Link project during the 2010-2011 influenza season. The analyses found that febrile seizures following TIV and PCV13 vaccines given to this age group were rare but did occur at higher than expected rates. The risk for febrile seizures peaked in children aged 16 months and were more common when the 2 vaccines were given during the same healthcare visit. In this group, about 1 additional febrile seizure occurred among every 2,200 children vaccinated. After assessing benefits and risks, ACIP continues to recommend that TIV and PCV13 be given concomitantly if both are recommended. Since February of 2013, when that language was presented to ACIP, some more information has been presented to ACIP with the following conclusions to the data. So basically, looking at surveillance since then, they've looked at formulation change is a factor, and when formulation did change, there was a change in what occurred. So when they looked at 2012, 2013, and 2013, 2014 seasons, with the formulation change, they saw no febrile seizure signal for IIV. VSD's Vaccine Safety Data Link found persistence in 2 seasons where the formulation stayed the same between 2010, 2011, and 2011, 2012. There was an additional investigation of fever. So the Clinical Immunization Safety Assessment Group, their study found a higher rate of fever. They didn't look at febrile seizure, but they looked at fever with simultaneous vaccination of IIV and PCV13 that was adjusted for DTaP vaccination. And then most recently, data was presented at the last meeting from Vaccine Safety Data Link and PRISM, and that's the Post-Licensure Rapid Immunization Safety Monitoring System. Basically, Harvard Medical School was the academic center. It involves safety surveillance involving 5 health insurance companies that looked at simultaneous vaccination. And they looked not only at IIV and PCV13, but they looked at DTaP as well. And there was a split in the studies on whether there is an effect of PCV13 and DTaP on the risk of febrile seizures with simultaneous vaccination with IIV. The VSD found highest risk seen when all 3 were administered simultaneously, at an attributable risk of 38 febrile seizures per 100,000 persons vaccinated. The PRISM study did not see an increased risk with TIV plus DTaP. So there really was no change, or basically, Immunization Safety Office has looked at these data and recommended no change in what we had presented to you in February 2013. And that is what is written in the draft that you have in front of you. At issue, of course, is the fact that these vaccines are recommended to prevent disease. Risk of disease is high. Febrile seizures are benign. And so hence our recommendation not to recommend withholding these vaccines, to give them simultaneously if they are recommended. The next topic is contraindications and precautions. It's in that section of the document. And this is the issue of vaccination during anesthesia, surgery, and hospitalization. Now, this is placed in this section because when we're talking about contraindications and precautions, we're talking about circumstances in which a provider has to decide whether or not to withhold completely a dose of vaccine, to wait to give it on the basis of, clinical conditions in the potential vaccine recipient. And so the specific topic that was presented also in February 2013 to the ACIP was vaccination during anesthesia, surgery, and hospitalization. And a bit of background here. First of all, let me give you the definition of what or not a definition, but an example of a particular type of precaution. Basically, a contraindication is a condition in which, should the vaccine recipient have that condition, the vaccine needs to be withheld. A precaution is a condition in a vaccine recipient. Decision point being you either decide to wait out if it's a temporary condition that is labeled as a precaution, or if it's a permanent condition, to do a risk-benefit analysis. We give deference to the provider to decide. And so an example of a precaution is acute, moderate, or severe illness. Vaccination can be deferred if someone does until they're better. So that's why this issue comes up and it appears in this section of the general recs. Some other background information that's relevant is the issue of vaccination during hospitalization. The Centers for Medicare and Medicaid Services uses as a performance measure the offering of inactivated influenza vaccine, or IIV, to patients who are hospitalized with pneumonia. Thirdly, by way of background, and the reason this issue first came up for General Recs is we were contacted in December of 2010 by an Australian pediatrician, contacted ACIP Executive Secretariat, asked about the issue of deferring elective surgeries when a vaccine has already been given. What about that issue? Should there be an interval? And so with all of that background, what the work group did prior to February 2013 is to look at the evidence that is out there, and of the studies. There were essentially 20 studies out there with very indirect evidence with respect to the immune response during hospitalization, surgery, and anesthesia. Of the studies, 15 addressed the immune response. But only 5 of them, actually 15 address the immune response, but don't address the issue of the immune response following a dose of vaccine. 5 of them looked specifically at the immune response to the vaccine, but the qualities of the studies, one was a systematic review, one was an editorial, and there were 3 letters. Of the remaining 15 studies that looked at the immune response following, during hospitalization, surgery, or anesthesia, they were basically inconsistent. There were 11 studies that looked at specific cell types, whether it's antibodies versus lymphocytes. And of those 11 studies, there really was quite a bit of variation between the different levels of the different types. Some showed levels increasing for one type and decreasing for others. So very, very inconsistent studies that were out there. There also were 6 papers that looked specifically at infants and children, and there was also a lot of inconsistency there. Some studies showed increases in the immune response during anesthesia, hospitalization, surgery in infants and toddlers. Some showed decreases in that immune response, and then some showed differences whether they were looking at toddlers versus infants in the same paper. So these studies were very, very inconsistent. And so in February 2013, we presented to ACIP our evidence summary that basically stated most studies that have explored the effect of surgery or anesthesia on the immune system were observational, included only infants and children, and were small and indirect in that they did not look at the immune effect on the response to vaccination specifically. They do not provide convincing evidence that recent anesthesia or surgery significantly significantly affect the response to vaccines. And along with this summary, which appears in the document, we also have the following statement that we put into the document. The optimal time for vaccination may be hospital discharge to avoid superimposing any vaccine-induced adverse effects on underlying conditions or avoid confusion in determining the etiology for conditions that occur or are exacerbated during the hospitalization. For patients who are deemed moderately or severely ill at the time of discharge, vaccination should occur at the earliest opportunity, that is, during immediate post-hospitalization follow-up care, including home or office visits, when patients' clinical symptoms have improved. So this was the statement that was presented in February 2013. There was some discussion on this language, specifically in the context of influenza vaccine. Is it basically too restrictive in terms of restricting the time period during which influenza vaccine can be given? So the ACIP General Recommendations Work Group went back and looked at this language, and we have tweaked it. We wanted to really emphasize both during the hospitalization or at discharge. And so on page 20, line 26 of your clean copy, you will see this language. We basically removed language that emphasizes, well, actually, that strikeout is just a flow issue of the language, but efforts should be made to ensure vaccine administration during the hospitalization or at discharge for patients who are deemed moderately or severely ill throughout the hospitalization. Vaccination should occur at the earliest opportunity, that is, during immediate post-hospitalization follow-up care, including home or office visits, when patients' clinical symptoms have improved. So I think the change in this language really ties this concept more into a precaution in terms of we talk about, in that we keep the language about patients deemed moderately or severely ill throughout the hospitalization. I think in those circumstances, yes, it makes sense to vaccinate near the end of the hospitalization as opposed to the beginning, but we wanted to put some language in there that would kind of allow providers to administer the vaccines at other times. And for the circumstances where we're talking about the decision to, well, first of all, the context in terms of elective surgeries following a dose of vaccine, because this was another issue that brought this to the work group. I want to remind ACIP of language that we have in the document that was added since 2011, but you did see it in February 2013. That states a new circumstance, a new criteria for labeling a situation a precaution, and that is what's underlined here. A precaution is a condition in a recipient that might increase the risk for a serious adverse reaction, might cause diagnostic confusion, or that might compromise the ability of the vaccine to produce immunity. On page 19, line 19 of your clean copy. So by adding this language, and it's in the same section of the general recs, it precedes the discussion of administration during hospitalization, anesthesia, and surgery. But I think this really does provide, to the extent that we really want this or need this, an out for providers that are concerned about elective surgeries, or even in the hospitalized patient, concern about the confusion of a post-surgical fever and the fact that giving a vaccine dose might cause diagnostic confusion in that respect. So it can be applied to those situations. So that was also added to this section. So that's timing and spacing and contraindications and precautions. Now, the next topic that I want to revisit is vaccine administration, safe injection practices. And this content was presented to ACIP in October of 2013. So we're 1 year out from last presentation of this content. And at the time, well, some background to this issue, is the specific discussion where we're talking about preparation and timely disposal of vaccines and multi-dose vials. And so CDC's Vaccine Safe Injection Practices program has some very specific language that they they had, and they still have some of this on their website, which laid out specific information regarding such topics as reinsertion of used needles in multi-dose vials, which is what we would understand that to be on that page. That makes sense. But what gave the general recommendations work group some fits, you could say, is where multi-dose vials can be opened in proximity to the patient. Very, very specific language that they need to be opened. They should not be open close to the patient. And the CDC Vaccine Safe Injection Practices program works as part of a work group to address these administration issues. They do impact the ACIP general recommendations. They have, pushed content that has cleared CDC with respect to this topic. But at the time of the presentation of this content during ACIP, it generated a lot of discussion. Here's the actual language. So, and it's really taken verbatim from that frequently asked questions website from Injection Safety. Vaccines should be drawn up in a designated clean medication area that is not adjacent to areas where potentially contaminated items are placed. Multi-dose vials to be used for more than one patient should not be kept or accessed in the immediate patient treatment area. This is to prevent inadvertent contamination of the vial through direct or indirect contact with potentially contaminated surfaces or equipment that could then lead to infections in subsequent patients. If a multi-dose vial enters the immediate patient treatment area, it should be discarded after use. So when this was presented, there was a lot of discussion in October 2013 about the context of community vaccination clinics, mass vaccination clinics, satellite clinics. How can this be done if the space in which to vaccinate is small? And so we met with those of us at CDC that are involved with the vaccine administration work group did discuss this and determined that a lot of this language is actually posted on CDC's website already. The guideline for isolation precautions for preventing transmission of infectious agents in healthcare settings, Jane Siegel's 2007 and HICPAC's statement, which is posted on CDC's website, but not all of it. And so we propose as a work group to leave multi-dose vials to be used for more than one patient should not be kept or accessed in the immediate patient treatment area. This is to prevent inadvertent contamination of the vial through direct or indirect contact with potentially contaminated surfaces or equipment that could then lead to infections in subsequent patients. However, we propose removing what really is restrictive language, the issue of discarding doses that enter the immediate patient treatment area, because this will be really, really problematic, I think, for various types of clinics. And this is taking a general perspective on this topic. Okay, so that's what we propose. It's page 34, line 26. The last topic to discuss is also in the vaccine administration section. And it's the issue of clinical implications of non-standard vaccination practices. So also discussed with ACIP in October of 2013. As far as some background, we are talking about the route of administration. And a lot of this stems from a different section of the general recommendations that discusses providers treating patients with hemophilia, because we have language in the general recommendations, again, that we don't anticipate changing, saying that for vaccines approved for intramuscular administration, providers can use the intramuscular route for patients with hemophilia if the bleeding risk is acceptable. Well, that's an out for doing that, right? I mean, they don't have to, that kind of provides some clinical discretion on the part of the provider. Might be taken as a license to administer vaccines subcutaneously. So the question is, should the doses count if given? And the challenge is that our evidence by which we have talked about this and provided guidance really varies by vaccine. First of all, I'll say that in the general recs, it does say that vaccines approved subcutaneously only may be given intramuscularly. Those we count. We're talking about vaccines for which administration is approved intramuscularly. Do you count them if they're given subcutaneously? Is it possible to generalize? And if you look at the data, you can see it's very, very challenging. First of all, if you look at hepatitis B vaccine, this, of course, is approved for intramuscular use. There are data that have been published, Sean Redfield and Coleman specifically, stating that immunogenicity is lower if administered either in the gluteus, presumably into subcutaneous deep fat, or intradermally. So we have some data that suggests that the immune response is not as good. We also have some newer studies that have been presented through our discussions with the folks at CDC that work with providers of hemophiliacs that seem to suggest comparable immunogenicity when comparing intramuscular versus subcutaneous vaccination, specifically performed in hemophiliacs receiving either HBV vaccine and are specifically at risk for infection by HPV. And so the data that we have, the studies that we have, because of the group in whom those studies are performed, really weakens and limits the evidence that we have for immunogenicity. Patients may be already exposed to the virus by virtue of their risk. They may have received HBIG, and the studies really don't tease that out. The ones that are listed here don't really tease out all of those possibilities. And so we basically concluded that in October of 2013 that we should kind of maintain our recommendation to repeat doses of hepatitis B vaccine given subcutaneously. There are some studies, though, that are ongoing, so this is a moving target. But again, we are going to continue to recommend repeating doses of this vaccine given subcutaneously. If you look at rabies vaccine, this one is approved for intramuscular vaccination. There is an intradermal vaccine used internationally, but not in the United States. Repeat doses administered in the gluteus, which presumably is a deep subcutaneous deep fat. We do not recommend, we do recommend repeating those doses. And we don't recommend changing that. Then we have human papillomavirus vaccine, which is approved for intramuscular injection. We don't have any data to indicate reduced immunogenicity or effectiveness if administered by another route, but we have been making recommendations to repeat this vaccine dose really on the basis of licensure alone. If it's an expert opinion, if it's administered subcutaneously, we recommend repeating HPV vaccine. Then there are some vaccines for which, if given subcutaneous, we do not recommend repeating the dose. Meningococcal conjugate vaccine is an example. It's approved for intramuscular administration. We know that providers will be administering this vaccine subcutaneously because of administration errors. The pure polysaccharide vaccine is approved for subcutaneous administration. But CDC did specifically look at data for subcutaneous administration of the conjugate vaccine. Small numbers, it was 38 people in all, but 36 out of the 38 that received it subcutaneously did have protective titers to this vaccine. That met higher than the cutoff, the established cutoff. So, and that has been published in the MMWR. So CDC does not recommend repeating these doses. During the process of revising this section, beginning in 2011 onward, we have looked for data that support not repeating doses. And hepatitis A vaccine is an example of one of these that's for which it's approved for IM administration, but there is a paper that discusses comparable immunogenicity found in children with hemophilia when administered hepatitis A vaccine either by the intramuscular or the subcutaneous route. The seroconversion was comparable. They looked at a cutoff value. The paper didn't really define a cutoff. Perhaps they were talking about fourfold rise. They did show significant differences when they looked at geometric mean titers, but the authors concluded that there really is not an appreciable difference in immunogenicity when Hep A vaccine is administered subcutaneously. And so we added to the language in October 2013 the HAV2 meningococcal conjugate vaccine as a vaccine for which we do not recommend repeating the dose. Hib vaccine we did not discuss in the October ACIP meeting, but there are data out there that suggests that perhaps we can count a dose of Hib vaccine. It's approved intramuscularly. There is a study, Christensen, in the Journal of Infectious Diseases in 1992, 20 splenectomized children and 1 hemophiliac. And the hemophiliac received the dose subcutaneously. Immunogenicity was comparable, and on this basis, we added Hib to the list of vaccines. So I think you can kind of see where we're going with this issue. We need to come up with some way, and it's not going to be easy, to really decide how to use the weight of the evidence that's there, where the weights are very different for vaccines. Can we generalize? We validate doses in the current draft with no need to repeat. If they're given subcutaneously, even though the evidence is weak for Hep A, Hib, and I don't think the evidence is really as weak for meningococcal conjugate vaccine, although the numbers are small. But again, we do not recommend repeating those doses. We invalidate doses supported by the evidence, which also is weak for hepatitis B vaccine and rabies vaccine. And we also invalidate doses really supported by FDA license, the package insert only for human papillomavirus vaccine. We don't have any guidance for other vaccines recommended to be administered intramuscularly, for example, DTaP vaccine, pneumococcal conjugate vaccine. And I did put together a statement, shared it with the general recommendations work group. This is not in your draft, so I'll ask you to look carefully at a proposed language that DTaP and PCV13, like all other vaccines approved for intramuscular use, should be administered by the intramuscular route. However, for DTaP and PCV13, there is no evidence to support repeating doses of these vaccines if given subcutaneously. Providers should address circumstances in which doses of these vaccines have been administered subcutaneously on a case-by-case basis. So those are the 4 big topics for which there have been changes to the draft. Before moving on to the discussion portion, I need to cover a couple more issues to discuss those 4 topics or anything in the draft that you have in front of you. Housekeeping issues, you might call it. The second half of the document, for which we will not be voting on today, we'll present it in February of 2015, contains a section that the ACIP has not been presented with yet. It's a very short section. ACIP has the draft content both in clean and track changes, basically vaccine information sources. This is a listing of organizations with websites and contact information. So I wanted to make sure that you saw that section today. Again, if there's any issues that come up on the basis of this question, we could definitely discuss, but that will not be voted on today. It'll be voted on with all of the other remaining topics in February. things like altered immunocompetence or vaccination records, vaccination programs, the programmatic content that many of you are familiar with, and this section. So basically, I've listed the organizations here on this slide that are mentioned with contact information in this section. I have a slide here that's kind of out of order, but I do want to thank the ACIP General Recommendations Work Group for all of the enriching discussion that has occurred on these topics and others, and happy to bring this content to ACIP. I have one more slide because I do want to talk about kind of the process. ACIP has seen the draft, and they've actually had a chance to weigh in on certain topics outside of the ones I just presented. I've received feedback from 6 ACIP members. Thank you very much for your comments. It's very helpful. 3 checked off no issues with the document. Another 3 had some specific comments to address, and these will be addressed, and I'll make sure they're not reflective in the draft that you have in front of you, but I will make sure these changes. The first 2 are kind of trivial. The first is in the timing and spacing section, and in the tables, I need to update the abbreviation. I think the 2011 document may have been published before we made this change from TIV to IIV, and things fell through. Obviously we have to catch up and make sure these are all changed. So I will definitely do that. I have, depending on intent, the decision process here has to be, if there's a discussion of safety data from the past, sometimes you need to kind of leave the discussion and leave it as TIV, and we can make that determination and make sure that which needs to be left TIV is left TIV. Because remember, IIV is inactivated influenza vaccine. It's kind of a general abbreviation that will be taken by providers as inclusive of IIV3, IIV4, CCIIV, and RIV3, because the General Rex talks about inactivated vaccines versus live vaccines. So there's going to be some, work that has to be done on this. The second set of comments I received, again, there is a topic in the timing and spacing section of the General Rex that discusses the suppressive effect of live vaccines on the response to not only the tuberculin skin tests, but also interferon gamma release assay tests for latent tuberculosis infection. It's already in the text. There was a request from ACIP to make sure that we say that in the other parts of the document, namely the tables. So I will make sure that gets changed. And then lastly, in the timing and spacing section, we talk about non-simultaneous vaccination and simultaneous vaccination. And we have the exception to our general rule that all vaccines can be administered simultaneously. We talk about, of course, PCV13 and Menactra. And we also talk about PPSV23 and PCV13. And there was a request to kind of change this language and put a more positive spin, de-emphasize the effect of dose of PPSV23 given first, and instead emphasize the positive priming effect of giving PCV13 first. Studies, opsonophagocytic studies that show really non-inferiority of the immune response when PCV13 is given first, followed by PPSV23. So we'll make sure that language is put in there. And I should also mention that this whole document following ACIP vote is going to go through CDC clearance. And so I envision us using specific language from the pneumococcal vaccine-specific statement that was just published. So the process is to, after some discussion, hopefully have a vote on the first half of the document. I'd love to hear from ACIP members, whether you already submitted response in writing or not, have a discussion of these topics, and then we'll do the second half of the document in February 2015. Thank you.
Thank you, Dr. Kroger. Open for discussion or questions? Dr. Kemp.
I think that HIB needs to be put in the same bucket as no data. Since we're talking about one subject, I can't understand. That seems really inconsistent to me to put that in the we have data about that. I also wanted to ask for the Hep A vaccine, how many children was that based on? Or I'm not sure if these were, children.
Right. So, okay, so just to kind of restate, so in terms of like, you're talking about intramuscular vaccine administered subcutaneously, not to count Hib vaccine on the basis of one study alone, not to count.
It's not one study, it's one child.
One child, rather, in the Christensen study. Sorry.
I just think it's fair to say we don't have data about that.
Okay.
But what about how many children were involved in the hepatitis A?
The hepatitis A study involved, I believe, it was 45 subjects. And all of them were anti-hepatitis A virus negative before.
So 45 children got it sub-Q, is what you're saying?
Yes.
Okay. Thanks.
I believe so, yep.
Yes, Dr. Rubin.
Yeah, and along the same lines, in terms of the sub-Q, given it inadvertently rather than IM, if it's a vaccine for which there is a serologic, definition of protection like hepatitis A or hepatitis B surface antibody, I'm wondering if there should be some language to go ahead and do that rather than for hemophiliac requiring who got it sub-Q requires factor to then get it IM. If one can show that that person generated sufficient amounts of surface antibody, that would be evidence of immunity.
Yes, Dr. Freierhofer.
Andrew, thanks so much for doing this. And I must say that after reading each part piece by piece, and then finally reading it again, every time I read it again, I catch something else. I learned something else, so thank you. First, kudos on page 1 for a great short and sweet explanation of the difference between conjugate and polysaccharide vaccines, which I think is a real help to practitioners. Another point on page 6 and page 12, and you just mentioned it, there is a warning not to give the MCV4-D or the Menactra and PCV13 together. And just doing a little sort of informal poll over here on this side of the table, I don't think a lot of us realize that. So if there's any way we can get the word out. On the adult schedule, the group that would apply to are the patients with functional or anatomic asplenia. And also, the abbreviation that you use, the MCV4-D, on our adult schedule, we're now using that MACWY. So all these acronyms for practitioners are very confusing. So I'd rather you put more acronyms that are the same thing than just limited. But really great job. Thank you so much.
Thank you.
Dr. Byington.
I'm sorry if I haven't read it, but I wanted to ask again about the anesthesia. We are getting a lot of questions from our anesthesiologist about delaying elective surgery post-immunization. Is there specific language that says you do not need to do this in the recs, or has it been addressed?
Well, we are putting language in there that vaccination can be administered at any time during the hospitalization. We're talking about the strength of the evidence. I don't think we're going to get as prescriptive as that based on the evidence to say that you should not wait, or...
Yes, the question we're getting is that the immunizations have already occurred in the outpatient setting, and now the child is coming in for an elective procedure, and we're having anesthesiologists turn them away for 10 days to 2 weeks following an immunization in the outpatient setting. And that seems like I would say that's a misinterpretation of what you're trying to get at here.
Well, it's the issue of how strongly we can kind of make that statement. And we're not going that far currently to say no need to wait an interval. We're not planning to put that language directly into the document. but I'm open to further, discussion on potentially doing that. But it's not in there currently. It's just basically saying kind of you can vaccinate during hospitalization, and providing the evidence that is there with respect to surgery, anesthesia.
I'm going to pick up on that point just a little bit, because for a lot of children who are coming in or have scheduled surgery, they're coming into their pediatrician, family physician, or other for a preoperative examination. Technically, that has to be 30 days before the procedure, and a lot of us will use that opportunity for catching up on vaccination. And so I think that's a very salient point here. At the same time, I'm taking a look on the flip side, and the taming down the language a little bit in terms of the vaccination prior to discharge. And I know a number of our surgeons are very reluctant to do that just because of the likelihood of a fever coming on. People don't stay in the hospital as long as they used to. They're being sent home, but with explicit instructions to call back if there's a fever. You never get the person who's discharged you, and oftentimes that ends up being an emergency room visit with labs and x-rays and so on. So it's not a minor thing as well. So I do appreciate that. Ms. Pellegrini.
Thank you, Andrew. Can we go back to the slide with the new language on DTaP, and I think it was HPV?
Yeah.
Is that it?
This one?
It was the new couple of sentences that you had that basically said there was no evidence on repeating doses for DTaP.
Oh, for febrile seizure?
Thank you.
Sorry, it'll be,
I think
we jump to
you had a
slide-
draft paragraph up that you were asking us
Yes,
to look very
yes.
carefully at.
Slide, I think we're talking about either slide 5 or 6. 5 is the language and 6 is the rationale.
No, I'm sorry, that wasn't it. I think it was for the subcutaneous versus
Oh, okay,
IM.
sorry. Yeah.
It was in italics, if that helps.
Okay. Let me just go through to it. The HPV one?
Right, so I think couple more slides maybe.
Oh,
There it is. Great. The second sentence there is, there's no evidence to support repeating doses if given subcutaneously. There's also no evidence to say you shouldn't repeat doses, correct? So I wondered if
Correct.
that should be stated more neutrally. There is no evidence to support, or I don't know what the right verb would be. And then it sounds like, if I'm reading this correctly, we're saying that providers just need to use their own best judgment about whether to repeat. And I'm wondering if there's any hope of having any evidence in the future to give them more constructive guidance than that.
well, what is happening now is, in the context of one patient will recommend repeating the dose where there's no, but in contexts where there may be hundreds, thousands of patients, that becomes more problematic and opens up the question, is it even possible to generalize on this issue at all? If you can't generalize, you could make the argument to take this out and not even kind of have any discussion of it in the general recommendations on immunization, which is a viable option. If it is possible to generalize, we have to say something for this circumstance. But I will, as far as flipping and saying there's no evidence to support validating the dose or some language to that effect, I'd be interested in hearing that can be done. I mean,
And it would be helpful to know if there's any kind of work going on out there right now that might give us some small amount of data even that we could use to base an improved recommendation on in the future.
Dr. Baker.
I want to go back to Dr. Byington's very good question and first couch it in children. So most children are having surgical procedures as outpatients. And if there is, I understand this no evidence problem. We didn't have much evidence when we recommended immunizing pregnant women. Can you say something like, and I don't know the answer, there's no contraindication? And I attribute that comment to my partner here, Bill Schaffner. So that's a question for you, Andrew. And before you answer, would the Red Book editor and secretary over there to Dr. Byington, in the part of the Red Book that talks about vaccines, what does the AAP recommend? Because I'm going to tell you the AAP members are much more responsive to you than to the ACIP. But Dr. Kroger?
So I think we can add that language in there because we're kind of setting up with the language that we currently have is to define this as a precaution. I mean, we've added that new factor. So it is a precaution. We could say it's not a contraindication. That seems like a very, in implementation of these recommendations, that's a very valid statement to make. And I think it is possible to put that language into the document as well.
I think that would be helpful. And then, Dr. Kimberlin, do you have a comment about this issue and, as I recall, part 1?
The only place that the word anesthesia or anesthetic appears in section 1 of the Red Book is talking about topical anesthesia to numb up the site before an injection.
Well, I know it's late, but you're the Red Book editor and everything can be done until the day of the printing. Maybe you might consider
I have to ask Dr.
adding
Pickering
something.
if that's okay.
Yes, Dr. Rubin.
I can just say that at our institution, what we've, not evidence-based, but we've come up with is a general suggestion that inactivated vaccines not be given within 2 days prior to surgery, live vaccines within 14 days prior to surgery, but if those vaccines are inadvertently given, there's no reason to cancel surgery.
And I think across all this discussion, we have to be very comfortable with the fact that we're never going to have sufficient evidence one way or another. And this is one where I think kind of the expert opinion is reasonable. Because I think if we wait, we're going to have a incomplete document for years. Further discussion, Dr. Rubin.
Yeah. I mean, I guess I just want to echo what Cynthia said there. It seems to me if we have a vaccine that's for IM use and it's given by the wrong route, unless we have evidence like we do that for certain ones that giving sub-Q generates adequate antibody, and I don't think we should give a pass for that. I think the vaccine should be repeated as a policy.
Yes, Dr. Lahr.
If I'm reading this correctly, on the Hib vaccine, it was 20 IM doses and 1 sub-Q dose, and that there is immunogenicity was comparable. That seems like a very single piece of evidence.
Agreed. Thank you.
Would the committee be more comfortable keeping the Hib as a repeat, given the importance of this vaccine in terms of child health, seeing that the evidence is fairly thin? Is that something
yes, we'll do that.
And I'm looking for additional hands. Do we feel that we can move on toward a vote on this at this point in time? And if we feel that way, do we have someone willing to make a motion? Dr. Vasquez.
Yeah, I'd like to put forth a motion that we approve the documents. as stated
With-
with the changes, the HIB.
So it has been so moved. Is there Dr. Bocchini? We have a move and second. Further discussion at this point? Dr. Bennett?
I'm just a little bit anxious about we've just changed a lot of things that you just presented. And I guess I'm a little bit anxious about voting on this without seeing the changes. I mean, I'm for one, was very concerned about the pneumococcal piece. And that wording is obviously going to have to be changed. And I'm just a little worried about this not coming back to us in some way. So is it sort of in spirit that we're voting on it, or?
Well, I think our options at this point would be to ask that this come back, for example, tomorrow morning with the explicit changes put forth, and we could have those in front of us at that point in time and make a vote. It might be crowded to do so yet this afternoon.
To do it this after. So it's on the slide set, basically show you what the changes are. That's doable.
That's doable, and would that be acceptable? So I think.
Or tomorrow,
If I'm the
either
only
is
one
fine.
that has this concern, we should go ahead, but I just have some worries.
Dr. Harrison.
No, I totally agree. We had this very complex discussion with a bunch of changes discussed, and I honestly don't fully understand what we're voting on either, so I think we need to do that.
So, Dr. Vasquez, would you be willing to remove your motion at this point in time with a stipulation that during unfinished business tomorrow morning, starting date, we will bring this back with the changes indicated for a revote?
Yes.
Okay, thank you. Okay, so I think any further discussion at this point in time? And Dr. Kroger, are you able to be back tomorrow morning?
Yes,
Okay,
I'll be back. Thank you.
Very good. At this point, as part of unfinished business, Dr. Andrew Kroger is going to come up and or at least present the changes that we discussed yesterday, preceding a vote on the general recommendations.
Thank you very much for this opportunity to present the unfinished business for general recommendations on immunization. Basically related to 3 discussion points yesterday. The first 2 relate to wording that I presented to you yesterday that needed some revision. Number 1, under the topic area of contraindications and precautions, the issue of vaccination during anesthesia, surgery, and hospitalization. The second discussion point, vaccine administration. Clinical implications of non-standard vaccination practices involves vaccination of vaccines approved by the intramuscular route when they're administered subcutaneously. And that breaks down into 2 subtopics, really. A revision of the statement that I gave about vaccines for which there are no data, and also the inclusion of HIB vaccine among vaccines for which there's no data. And then the third discussion point from yesterday involved a revision which was shared previous to this meeting from ACIP regarding simultaneous vaccination of pneumococcal conjugate vaccine and pneumococcal polysaccharide vaccine, or at least it falls under the general recs category of simultaneous. So it's language about these 2 vaccines and how they need to be separated. You didn't really see that language yesterday, so I wanted to show that to you today. So first, with respect to contraindications and precautions, I showed you our evidence summary based on the data or lack thereof regarding whether you need an interval before or after vaccines and surgery anesthesia. I have not changed this slide at all. This is what I showed you yesterday as far as our evidence summary. Basically, the evidence that we have are observational studies, indirect studies, and don't look at the immune effect on the response to vaccination specifically, or at least the vast majority of studies do not do that. And do not provide convincing evidence that recent anesthesia or surgery significantly affect the response to vaccines. I'm not proposing a change to that, nor am I proposing a change to our action statement also presented yesterday. Efforts should be made to ensure vaccine administration during the hospitalization or at discharge. For patients who are deemed moderately or severely ill throughout the hospitalization, vaccination should occur at the earliest opportunity, that is, during the immediate post-hospitalization follow-up care, including home or office visits when patients' clinical symptoms have improved. The concerns from ACIP yesterday revolved around and had some focus on the issue of patients recently vaccinated that may be scheduled for elective surgery. It was noted that some providers already use intervals. However, we do need to keep the door open for some flexibility as to the timing of when to vaccinate. There were also concerns expressed yesterday from some of the liaison members in American Academy of Pediatrics and Infectious Diseases Society of America regarding the current language that's in the document defining hospitalization, surgery, anesthesia as a precaution, which might lead to withholding vaccines that can actually be protective by preventing disease in someone that has upcoming surgery. So, for instance, the challenge of how difficult it is to generalize when we're talking about influenza vaccine or MMR vaccine. The concern may be different for different vaccines. So we need some guidance, but we cannot be too prohibitive. And so the proposal is to connect those two passages that I showed you earlier with a bridging statement about the fact that current, recent, or upcoming anesthesia, surgery, or hospitalization is not a contraindication to vaccination. So this is how it would look. It would fit right between those two, the two passages that I showed you earlier, the evidence statement, which is in italics, and then where it starts current, recent, you can see I've placed that sentence in there, followed by the action statement that efforts should be made to ensure vaccine administration during hospitalization or at discharge. So that's our proposal for discussion point 1. For discussion point 2, the issue of vaccine administration, clinical implications of non-standard vaccination practices. Here is the statement that I showed you yesterday. DTaP, and this is for vaccines for which we do not have convincing data that you either should count or not count a dose of this vaccine given subcutaneously. So yesterday, it stated, DTaP and PCV13, like all other vaccines approved for intramuscular use, should be administered by the intramuscular route. However, for DTaP and PCV13, there is no evidence to support repeating doses of these vaccines if given subcutaneously. Providers should address circumstances in which doses of these vaccines have been administered subcutaneously on a case-by-case basis. Concerns from ACIP yesterday included the issue of this current language and where should the burden be on the evidence. Should the burden be on the evidence to demonstrate that doses administered subcutaneously need to be repeated, basically a more data-driven, or should burden be placed on the evidence that to demonstrate that the doses need to be counted or can be counted? And we can't really do that because there is no such evidence for HPV vaccine in this respect. Another concern was, and this relates to the issue of Hib vaccine, we originally yesterday were going to group Hib vaccine with hepatitis A vaccine and meningococcal conjugate vaccine, for which there is evidence that you can count a dose given subcutaneously. The comments yesterday were we should actually place Hib with DTaP and PCV13 with respect to we do not have evidence to count a dose given subcutaneously. And all of this was in the context of providing more neutral language that does not really provide a specific action step. So if you take the language that I showed you yesterday and we add, first of all, Hib to the list of these 3 vaccines. So DTaP, Hib, and PCV13, like all other vaccines approved for intramuscular use, should be administered by the intramuscular route. However, for DTaP, Hib, and PCV13, there is no evidence related to immunogenicity of these 3 vaccines given subcutaneously. Providers should address circumstances in which doses of these vaccines have been administered subcutaneously on a case-by-case basis. Okay, so that's discussion point 2, and then here's what it looks like cleaned up. Okay? Lastly, the third discussion point was the issue of simultaneous administration, which is in the timing and spacing of immunobiologics, and we state in this section two exceptions to the issue that all vaccines can be administered simultaneously, and the important one is this issue with PCV13 and PPSV23. This is the way, and so this was a comment was sent to me from ACIP on October 10th. Or actually, we sent out the document on October 10th to ACIP, and this is the way the language read at that time. In patients recommended for both PCV13 and PPSV23, the two vaccines should not be administered simultaneously. The immune response to pneumococcal vaccines, particularly PPSV23, stimulates an immune response that inhibits the ability to respond to a follow-up dose of pneumococcal vaccine given shortly thereafter. Because this immune blunting effect is stronger with PPSV23, PCV13 should be administered first, and PPSV23 should be administered no earlier than 8 weeks later. As the immune blunting effect is stronger with PPSV23, if PPSV23 has been administered first, PCV13 should be administered no earlier than 1 year later. Comments received from ACIP basically suggested to emphasize the positive priming effect of PCV13 as opposed to the effect of PPSV23 to blunt the immune response to subsequent doses. And ACIP membership yesterday wanted to see this change before voting. And so the proposal is to really adopt language from the pneumococcal vaccine specific statement, the ACIP statement from 2014. And of course, the language will need to flow with the rest of the general recommendations document. And so here's the old, again, language. And the idea is basically to remove down to here and really add this language. So the way this would read now is, and this is really taken almost completely from the pneumococcal specific statement, in patients recommended for both PCV13 and PPSV23, the two vaccines should not be administered simultaneously. Immunogenicity studies evaluating responses to PCV7 and PPSV23 administered in series showed a better immune response when PCV7 was administered first. An evaluation of immune response after a second pneumococcal vaccination administered 1 year after the initial study doses showed that subjects who received PPSV23 as the initial study dose had lower antibody responses after subsequent administration of PCV13 than those who had received PCV13 as the initial dose followed by a dose of PPSV23, regardless of the level of the initial response to PPSV23. And then the rest is struck out, and PCV13 should be administered first. If PPSV23 has been administered first, PCV13 should be administered no earlier than 1 year later. So that is the third discussion point. So now I conclude there and open it up to ACIP to comment and hopefully vote.
Thank you, Dr. Kroger, for your hard work in putting this together overnight. Dr. Blancha.
Can you go back to that previous slide, please? My only suggestion on this, I think it's very good. Put the action item at the top. That is, after the first sentence, it says the two vaccines should not be administered simultaneously. Then take that sentence that's the second to the last, PCV13 should be administered first. Put that up right at the top. That's sort of the action item rather than putting it at the very end of the paragraph.
I will do that. And actually, I can't see the presentation on this screen, so I can't type it in right now, but I will do that. I will definitely do that.
Dr. Reingold.
Sorry, could you put the first statement back up, the one about surgery and anesthesia, the revised language?
The proposal, right? What we propose to say?
I'm just curious. I haven't been a clinician for a long time, but I don't know what I would do with that last sentence about on a case-by-case basis. I'm not sure it's up there at the moment. Maybe it's the next slide.
So the case-by-case basis issue is related to the site, the intramuscular vaccine administered subcutaneously.
Yeah, sorry,
that one?
Yeah, sorry. That's the one I meant.
Okay.
Apologize.
That's the old. Here's the new.
So I'm curious what people from the clinical world, how they interpret that and if they find that a helpful statement, because I don't know what that means, or I don't know what I would do with that if I were a clinician.
I'm willing to answer there to some extent. In all my years, I'm not aware of any of my patients ever being misadministered an IM in a sub-Q route, first of all. And I think the second thing is it depends on the situation, that if it, just my thought processes are, if it's a repeat immunization for something that they've already been primed for, I'm not concerned. If it's one of the initial Hib vaccines, I feel strongly that that one needs to be done appropriately. So this is one where we're kind of operating blind. We don't have the evidence one way or the other, and I doubt we're going to see that. So this is one of those situations where kind of a fuzzy statement may be acceptable. Dr. Lahr.
I agree that a fuzzy statement is appropriate because we don't have the evidence, but I also think that most people reading this are smart enough to understand that if you say we don't have evidence in the statement, they'll sort of not call us sort of saying, why did you make that statement? So I might put that bluntly in there, we don't have evidence in one way or the other.
Ms. Groom.
Thanks. I mean, I just think on this issue, previously, at least you knew that you probably didn't need to repeat these 3 vaccines, but the way it's worded now, you just really don't know what you should be doing, if you should repeat them or not. Just saying there's no evidence doesn't really leave the clinician with an idea. At least previously, it was suggesting that you probably didn't need to repeat these vaccines.
From an implementation standpoint, when these vaccines are given, we've typically said in a one-to-one, if it's just one patient, we have said you should repeat it. The issue gets when there's many, many doses given, hence the case-by-case basis issue for implementation.
Other discussion? Yes, Dr. Kemp.
So my memory is that this is in the context of us already saying there is some evidence for a few vaccines, because the however is kind of odd here. So this is following a statement saying for these vaccines there seems to be evidence that sub-Q is adequate, right? So that this would then be saying for secondarily for these other vaccines there is no evidence.
There's adequate evidence for meningococcal conjugate vaccine and hepatitis A vaccine.
Okay, because in that context I think this makes more sense and gives some, to me it says what it needs to say. There isn't any evidence.
Other comment? Seeing none, I'm going to go back to Dr. Vasquez, who I believe made the motion yesterday.
I'd like to make the motion to approve the revised wording as it was presented today.
And if my memory is intact, I think Dr. Bocchini had previously seconded. So,
second.
Further discussion? Dr. Riley, would you like to start? And we can go to your right, which would be Dr. Bocchini.
Laura Riley, yes.
Bocchini, yes.
Vasquez, yes.
Reingold, yes.
Pellegrini, yes.
Tempte, yes.
Bennett, yes.
Rubin, yes.
Romero, yes.
Harrison, yes.
Belongia, yes.
Karen, yes.
Camp, yes.
And the motion passes 13 in favor, 0 against, and 2 who are absent. With that, I thank you very much for your time.